Imagine you're standing in this brightly lit corridor of a psychiatric unit,
Okay.
and a few feet away, a patient is aggressively pacing. Like their jaw is tight, their fists are completely clenched, and they're starting to shout at the wall.
Right. A really tense situation.
Yeah, exactly. And if you're a compassionate human being, your immediate instinct, the instinct you've basically honed over a lifetime of social interactions, is to step forward, you know, put a calming hand out,
Mm.
and ask, hey, what's wrong? Like, why are you so upset?
Which is, I mean, that's exactly what we're taught to do in polite society. You see distress and you attempt to mediate it through logic and proximity.
Right. But if you follow that very natural, very human instinct in this specific clinical environment, you're likely going to escalate a crisis and potentially get yourself or someone else seriously injured.
Oh, absolutely.
And that right there is the core of what we're unpacking in today's deep dive. You've handed us this massive, comprehensive study guide for mental health nursing. It's just a towering stack of complex clinical scenarios, severe diagnoses, high-stakes interventions.
It's a lot to take in.
It really is. And if you are the one staring down this material trying to memorize it, it can feel like you're trying to learn a completely alien language.
Because in a lot of ways, you are. Psychiatric nursing operates in this space where standard medical algorithms meet the unpredictable reality of human behavior.
Yeah.
You're mapping the fractured mind while trying to keep everyone in the room physically safe. And the overarching theme of this entire body of knowledge is that clinical mental health care frequently requires you to completely override your everyday human instincts.
It's totally counterintuitive sometimes.
Exactly. You have to favor highly structured, evidence-based protocols over what just feels right in the moment.
So our mission today isn't just to, read you a list of correct answers from this guide. That wouldn't stick.
No, not at all.
We're going to forensically break down the logic of this field. We're going to explore the physiological and psychological mechanisms behind why the right interventions work. And critically, we're going to dissect those initial gut instinct reactions, the wrong turns, to understand exactly why they fail.
I love that. We're pulling apart the why and the how rather than just the what.
Right. And we have to start that breakdown at the absolute bedrock of the practice.
The foundation.
Yeah. Before you can administer a medication, before you can de-escalate a crisis, you have to establish the therapeutic relationship. The entire framework rests on a foundation of trust and fiercely guarded ethical boundaries.
Which sounds pretty straightforward until you're actually looking at a patient.
Right. Let's take the very first encounter on a unit. So you have a newly admitted client who is sitting there visibly withdrawn and fearful.
Very common.
And my first thought, looking at someone who is scared and isolated, is that they need community. I want to walk them out to the day room, introduce them to some friendly faces, and maybe sit down and ask them how they've successfully coped with stress in the past. Get them talking right.
It's a beautiful impulse, it really is, and clinically it is completely backward.
Wait, really?
Yeah. The evidence-based protocol for the orientation phase of a nurse-client relationship dictates that your absolute first action is to inform the client that their admission and their conversations are confidential.
Okay, walk us through the mechanism of why that takes precedence over making them feel socially welcome.
Because you cannot build therapeutic rapport without a baseline of safety. I mean, a fearful, withdrawn client is in a state of hyperarousal and vulnerability. Their nervous system is likely treating everything as a threat.
Oh, that makes sense.
Right. If you take that raw, exposed nervous system and push it into a crowded day room, you're flooding them with unpredictable social stimuli before you've even established that the ground they're standing on is solid.
It's sensory and emotional overload.
Exactly. And pressing them immediately about their past coping strategies or demanding behavioral changes is equally invasive. You're asking for vulnerability before you've provided security.
Wow.
Yeah, confidentiality isn't just a legal form, It's the emotional contract that says, I am placing a wall around us. What happens inside this wall is safe from the outside world. You have to build the container before you can pour anything into it.
That makes profound sense. You secure the perimeter first.
Exactly.
And speaking of how we interpret these early interactions, there's this fascinating bias we carry into clinical settings when it comes to nonverbal cues.
Oh, the tendency to over-pathologize. We see it constantly.
Right. So there's a scenario here where a nurse is conducting an initial interview, and the client is maintaining steady eye contact and leaning forward in their chair.
Yep.
Now, when you're studying psychiatric disorders all day, it's incredibly easy to look at that behavior and think, okay, Are they attempting to manipulate me? Is this aggressive posturing? Or are they inappropriately physically attracted to me?
You start looking for the disease in every single gesture.
Yes.
But standard nonverbal behavioral assessments tell us something beautifully mundane. Leaning forward and maintaining eye contact usually just means the person is actively engaged and interested in the conversation.
So why do we fall into the trap of assuming manipulation right out of the gate?
Because of the environment. When you work with severe pathology, your radar is always up. But if you misdiagnose simple human engagement as manipulation or romantic attraction, you immediately introduce a toxic bias into the therapeutic relationship.
You're treating them like a threat.
You start treating them with suspicion. It's a vital clinical skill to recognize normal baseline behavior so you don't treat a healthy interaction as a symptom.
We have to remember what normal looks like. Okay, let's push into the ethical principles that govern this space, because they often clash directly with our personal comfort zones. I want to look at the principle of justice.
A big one.
Yeah. This scenario presents a nurse who's managing a unit, and one of the clients is being consistently verbally abusive, just hurling insults.
A deeply unpleasant reality of the job, unfortunately.
Right. Now, if someone is screaming at me, my survival instinct and, frankly, my preference is to check their vital signs, ensure they aren't bleeding, and then get as far away from them as possible.
Naturally.
Maybe I'll spend more time in the room with the nice, quiet patient down the hall. But applying the ethical principle of justice means doing the exact opposite.
Yes. To fulfill the principle of justice, the nurse must spend adequate, equitable time with the verbally abusive client.
Even though it feels terrible.
Right.
Explain the ethical framework here, like why is walking away a violation?
Because justice in medical ethics is about the equitable distribution of resources. And in psychiatric nursing, your time, your presence, and your assessment skills are the primary resources. If you avoid the abusive client, you are actively degrading their standard of care simply because they make you uncomfortable. You're penalizing them for the symptoms of their illness.
What if I try to make it fair in other ways? Like, what if I allow the abusive client to choose their own recreational activities? Or I spend a lot of time giving them perfectly accurate information about their prognosis.
Well, those actions fulfill other ethical principles, but not justice. Allowing them to choose activities respects autonomy, their right to self-determination. Providing accurate prognosis information is veracity the duty to tell the truth.
But justice is different.
Justice is strictly about equal allocation of care. It's the unwavering commitment to treat the combative patient with the exact same clinical dedication as the pleasant one.
Which perfectly sets up the next ethical collision. Non-maleficence, the duty to do no harm.
Right.
And sometimes doing no harm means completely stripping a patient of their choices. Like, we have a client who's making repeated, credible physical threats toward other patients on the unit. However, the client explicitly states, I do not want to leave this unit, I want to stay here. But the nurse initiates a transfer to a specialized unit equipped for violent behavior anyway.
This is where ethical principles operate in a strict hierarchy based on immediate physical threat.
Right, because if we respect their request to stay, we're upholding their autonomy. But by transferring them against their will, we're overriding that autonomy.
We are overriding it because the principle of non-maleficence, the absolute duty to prevent harm, takes precedence over self-determination when violence is imminent.
That makes sense.
The nurse is a steward of the entire therapeutic milieu. If you allow a highly volatile client to remain in a space where they can injure vulnerable people, you become complicit in that harm.
So the transfer isn't a punishment.
No.
It's a clinical intervention to protect the ecosystem of the unit.
Exactly. The concepts of veracity or justice don't apply when someone is winding up to throw a punch. You secure the physical safety of the environment first.
And that transition from conceptual ethics to physical safety is where the rubber meets the road. Managing the milieu, the environment itself, is a massive part of this practice.
Huge.
It's not just the walls and the beds, it's the lighting, the noise, the emotional temperature of the room.
The milieu is a living, breathing therapeutic tool. Or, if mismanaged, it's an accelerant for pathology.
Let's look at how we control it. We have a child diagnosed with conduct disorder who is in an acute, highly destructive phase. They're throwing objects across the room, kicking furniture, kicking staff.
A full crisis.
Yeah. My initial thought, especially with a child, is to try and guide them through it. Teach them relaxation breathing or sit them down and encourage them to verbally express the feelings behind the anger.
And if you attempt to sit a child down who is in the middle of a violent, destructive outburst to teach them deep breathing, you are going to get a chair thrown at your head.
Because it's physiologically impossible for them to process it, right?
Completely impossible. When a child, or an adult for that matter, is in a state of acute physical aggression, their sympathetic nervous system is entirely in the driver's seat. They are in fight or flight.
Right.
The prefrontal cortex, which handles logic, language processing, and emotional regulation, is essentially offline. You cannot teach a coping mechanism to a brain that is actively preparing for combat.
So what is the actual intervention?
You reduce environmental stimuli. That is the only immediate priority.
To strip it down.
Yes. You dim the lights, you remove other patients from the room so there's no audience, you lower the volume of your voice, and you strip away anything that is feeding the sensory overload.
Wow.
You attempt to mechanically downregulate their nervous system by starving it of input. Once they are safe and regulated, then you can talk about assertiveness training and feelings, but in the crisis, you just remove the fuel.
Let's look at another environmental clash, this time between two patients.
Yeah.
You have a client recently diagnosed with bipolar disorder who was placed in a semi-private room with a client experiencing severe depression.
Oh, boy.
The depressed client approaches the nurse, exhausted, and says, "My roommate never sleeps. They're pacing and talking all night, and I can't get any rest."
This is a textbook collision of opposing energy states.
Now, a very tempting quick fix here would be to utilize pharmacology. Why not give the depressed patient a sedative so they can sleep through the noise? Or, conversely, give the manic patient a heavy sleep aid to knock them out and force them to rest.
Because doing either of those things crosses a massive clinical and ethical line. You are discussing the use of a chemical restraint to solve a logistical administrative problem.
Oh, wow. Using medication for the convenience of the unit.
Precisely. And it is a profound violation of standards. Clients experiencing the acute manic phase of bipolar disorder are naturally going to disrupt the milieu. The hyperverbalization, the flight of ideas, the relentless psychomotor agitation that is the disease process manifesting.
Right.
You do not drug them into submission just because the room assignment is inconvenient.
So the intervention is purely environmental.
You fix the environment. You move the bipolar client to a private room.
Simple as that.
This achieves two crucial things. It protects the sleep architecture of the depressed client, which is vital for their recovery, and it provides a lower stimulation environment for the manic client, which helps de-escalate their episode. You alter the space, not the brain chemistry, to solve a conflict.
But what happens when the conflict isn't just an annoyance, but a danger? There's a dense section here on mandatory reporting and anticipating violence. The question asks which of four very serious client scenarios legally requires the nurse to break confidentiality and notify external authorities.
This tests the boundary between clinical concern and legal obligation.
The scenarios are an adolescent with anorexia nervosa who has a dangerously low BMI of 17, a depressed parent who flatly states they have no interest in caring for their children anymore, a client in the manic phase of bipolar disorder who has active genital herpes and reports having multiple anonymous sexual partners, and finally a client with borderline personality disorder who explicitly threatens to severely harm their roommate.
They are all alarming, but only the threat of violence against the roommate crosses the specific legal threshold that mandates breaking confidentiality.
I really want to dig into why the others don't qualify, because my alarm bells are ringing for all of them. I mean, an adolescent with a BMI of 17 is starving to death.
Yes.
A depressed parent neglecting their kids sounds like immediate child abuse. And someone recklessly spreading an incurable virus feels like a public health crisis.
Yeah.
Why aren't we calling the police or Child Protective Services immediately for those three?
It comes down to the immediacy and specificity of external harm. Let's break them down.
Okay.
The adolescent with anorexia is in severe medical danger, but it is self-directed harm occurring within a medical facility. The intervention is acute medical stabilization and psychiatric care, not police involvement.
What about the depressed parent?
A statement of lack of interest in parenting is a hallmark symptom of severe depression. It's anhedonia and overwhelming fatigue. It requires an immediate social work consult, a deep assessment of the family support system, and safety planning. But expressing the feeling of apathy does not equate to actionable physical abuse that legally breaks AP in that exact moment without further investigation.
And the client's spreading the virus.
You are looking at poor judgment and impulsive behavior secondary to mania. It requires intense, immediate education, counseling, and disease management. But you do not have the legal authority to report a patient to the authorities for making reckless sexual choices.
But the threat against the roommate is different.
Fundamentally different. Borderline personality disorder can feature profound interpersonal instability and sudden aggression. When a patient makes a specific, credible threat of physical violence against an identifiable third party, the duty to warn and protect legally supersedes patient confidentiality. You are mandated to intervene to prevent a crime.
So let's bring that threat right into the hallway. We're back to our opening scenario. The pre-violence phase. A client is pacing, fists clenched, hurling verbal abuse at the nursing staff. We establish that our natural instinct to ask, "Why are you upset?" is a bad idea because the amygdala is hijacked. What about other physical instincts?
Like what?
My next thought is to step in close, remain right within arm's length, so I can intervene quickly if they lunge.
If you step into their personal space bubble while they are escalating, you are transforming yourself from an observer into a target.
Because I'm perceived as a threat.
Yes. Their spatial awareness is completely distorted by adrenaline. Standing within arm's length makes you an immediate, accessible object for physical striking. You must maintain a significant physical distance.
Then what about jumping straight to mechanical restraints? Lock them down before they can swing.
Restraints are never a preventative measure for anticipated violence. They are the absolute last resort for active violence. If you attempt to restrain a pacing verbal client, you are the one initiating the physical altercation.
So the correct move is the invisible safety net.
You ensure that security personnel are available in the background, but crucially, you keep them out of the client's direct line of sight.
Oh, to avoid triggering them.
Exactly. Seeing a tactical team of security guards can trigger a cornered animal response. You want the muscle available in seconds if verbal de-escalation fails, but you don't wave it in their face.
Which leads us to the grim reality of when that de-escalation does fail. The application of mechanical restraints and seclusion. This is arguably the most highly regulated intervention in nursing because of the profound ethical weight it carries.
You are legally suspending a person's basic constitutional rights, their freedom of movement, in the name of immediate survival. The protocols have zero margin for error.
The study guide dictates an incredibly rigid framework. You don't just lock a patient down and walk away. A staff member must physically check on the restrained client every 15 minutes.
Not 30 minutes, not hourly, every 15 minutes.
Why?
Why? Because mechanical restraints can rapidly compromise peripheral circulation. If a restraint is too tight, you can cause permanent nerve damage or tissue necrosis in a matter of minutes. You are also checking their airway and ensuring they aren't engaging in self-harm against the restraints.
The guide also emphasizes that you cannot keep them NPO nothing by mouth. You have to address their basic physiology.
They are trapped, they cannot get water, they cannot access a toilet. The nurse becomes entirely responsible for their hydration, their nutrition, and their elimination needs. Ignoring those is inhumane.
There is also a strict rule about positioning. You can never, ever place a restrained client in a prone position face down on the bed.
It is a lethal risk. Prone positioning combined with the extreme physical exertion of fighting restraints creates a massive risk for positional asphyxia. Their chest cannot expand against the mattress.
That's terrifying.
It is. Furthermore, if they vomit while prone and restrained, they will aspirate and drown in their own fluids. They must be positioned comfortably, usually supine or side-lying, with an absolutely unobstructed airway.
And the release process is gradual. You remove one restraint at a time as they regain internal control. But how do you assess that control? How do you know when it's working?
That's the tricky part.
Right. The guide gives us 3 distinct patient presentations to evaluate. Let's say the restrained client is now following basic instructions and can verbally explain the factors that cause their violent outburst.
That is the gold standard of improvement. They are demonstrating an internal locus of control and returning insight. The prefrontal cortex is coming back online. You would begin the process of releasing restraints.
What if they have stopped yelling, but they are completely silent, just glaring intensely at the nursing staff?
Their clinical condition has not changed. The absence of screaming does not mean the absence of violence.
Interesting.
A silent, glaring posture indicates the internal pressure cooker is still at maximum capacity. They're just expressing the aggression non-verbally. Do not release the restraints.
And if you approach them to offer a sip of water and they attempt to bite you,
Their condition has declined. The agitation is escalating to the point where they are attacking the source of basic comfort. The intervention must be maintained, and pharmacological support may need to be reassessed.
once the crisis is over, the protocol mandates a debriefing.
Hmm.
But it's a two-part process. You debrief with the staff and you debrief with the client.
The staff debrief is about quality assurance and trauma processing for the team. Did we miss the early warning signs? Could we have de-escalated better? Did we follow the legal protocol perfectly during the takedown?
And the client debrief.
It's therapeutic. Being restrained is an inherently traumatic experience. You sit down with the client once they are completely lucid and you dissect the event.
Right.
What triggered you? How did it feel when the staff approached? What can we, together, do differently next time so that you never have to be restrained again? It rebuilds the trust that the physical altercation strained.
That transition from managing outward behavior to understanding the internal trigger is crucial. We need to move from the physical space of the milieu into the internal landscape of the mind. Let's explore disorders of mood, starting with the heavy, pervasive weight of depression. And the first thing we have to do is assess the risk factors during an initial intake.
Identifying who is most vulnerable before the disease fully takes hold.
The scenario asks us to identify a factor that places a client at a significantly increased risk for developing depression. The options are a recent marriage, receiving a major promotion at work, being assigned male at birth, or having a diagnosis of COPD, chronic obstructive pulmonary disease.
The correct risk factor is COPD, and this highlights the inextricable link between the physical body and the psychiatric mind.
I think a lot of people separate them. They think of depression as purely a chemical imbalance in the brain or a reaction to a tragic life event. Why does a lung disease trigger it?
Because chronic medical illnesses, especially ones that impair oxygenation and mobility like COPD, place a massive, relentless burden on a person's entire system. It drains their physiological reserves.
Oh, I see.
It strips away their independence. They can't walk upstairs. They can't participate in hobbies. This chronic systemic stress, combined with the loss of autonomy, creates a perfect breeding ground for severe depressive disorders.
The other factors are red herrings. Marriage is statistically a protective factor because it provides a built-in social support network. A promotion is stressful, sure, but it's an acute positive stress, eustress, not distress. And demographically, individuals assigned female at birth are diagnosed with depression at much higher rates than those assigned male at birth.
You have to look for the chronic systemic burdens.
So once a patient is treated for an acute depressive episode and is preparing for discharge, we have to teach them how to prevent a relapse. And this is where we run into one of the most fascinating concepts in psychiatric nursing, the danger of false reassurance.
It is the enemy of therapeutic trust.
The study guide dictates that the correct teaching for preventing relapse is to train the patient to look for early behavioral changes, specifically decreased social involvement. If they start canceling plans with friends, that is the early warning system.
Because withdrawal is almost always the first domino to fall. Before the deep sadness hits, the energy to engage dissipates.
But I want to look at what the nurse should never say to the discharging patient. Statements like, "Things will definitely get better," or "These medications will guarantee you don't end up back in the hospital," or "It's highly unlikely you will ever have an episode this bad again."
What do all of those statements have in common?
They sound exactly like what a loving family member or a well-meaning friend would say as they drive you home from the hospital. They're trying to wrap the patient in optimism.
And in a clinical setting, that blind optimism is toxic.
Break that down for me. Why is it toxic to tell a patient things will get better?
Because depression is an episodic, chronic illness with a high rate of relapse. If a nurse, an authority figure in a scrub top, looks a vulnerable patient in the eye and guarantees that the medication will prevent another hospitalization, the nurse is making a promise they cannot keep.
And when the patient inevitably experiences a dip in their mood 6 months later,
The fallout is catastrophic. Not only does the patient feel like they have personally failed, but their trust in the medical system is shattered. The nurse told me this wouldn't happen, so the medicine must be broken or I must be unfixable.
wow, that's heavy.
It is. False reassurance invalidates the reality of the disease. You have to teach them the stark truth. Relapse is a real possibility, and here's the exact map of how we catch it early. You arm them with vigilance, not fairy tales.
That is a staggering difference between being a good friend and being a good clinician. And that vigilance becomes life or death when we talk about assessing suicide risk. A client with severe depression and a history of repeated attempts makes a statement during rounds. The nurse has to identify which statement indicates a decreased risk of imminent self-harm.
Recognizing the subtle linguistics of suicidal ideation is a master skill.
I am going to read 4 statements, and I want you to tell me why the first 3 are actually massive, glaring red flags, because to an untrained ear, they sound like improvements.
Let's hear them.
Statement 1, don't worry, I finally have all my financial affairs in order.
That is a logistical red flag. Getting finances in order, updating a will, or suddenly giving away prized possessions indicates that the client has moved from abstract ideation to finalizing a concrete plan. They're closing out their accounts, literally and metaphorically.
Statement 2, suddenly I have enough energy to do absolutely anything.
This is perhaps the most terrifying presentation of all. If a client has been profoundly lethargically depressed for weeks, and overnight they display a sudden, brilliant burst of energy, it often means they have finally made the definitive decision to end their life.
Wait, really? The energy comes from the decision?
Yes, the agonizing ambivalence is gone. The relief of that final decision provides a surge of energy, and crucially, they now have the physical energy required to carry out the attempt.
Statement 3, thank you for taking such good care of me during my stay.
A serene, unprompted expression of ultimate gratitude from a chronically suicidal patient is very often a final goodbye. They are tying up emotional loose ends with their caregivers before they act.
Which leaves only one statement that actually demonstrates a decreased risk. It is getting easier for me to talk about my feelings with the group.
Because it indicates active, forward-looking engagement with the therapeutic process. They are reaching out for connection, not closing the doors. They're participating in the hard work of living.
Let's swing the pendulum to the opposite extreme of the mood spectrum, bipolar mania. We are doing discharge teaching with the partner of a newly diagnosed bipolar patient, teaching them how to identify the onset of acute mania.
The partner is the first line of defense. They see the shifts before the clinical team does.
We have to tell the partner what the most critical early warning sign is. And it isn't obsessive attention to detail or sudden isolation or fatigue. The absolute canary in the coal mine is an inability to sleep.
Sleep architecture is the foundational pillar of bipolar management.
Why is a few days of insomnia a medical emergency for a manic patient?
Because during acute mania, the brain is flooded with excitatory neurotransmitters. It's firing at 1,000,000 miles an hour. The patient feels euphoric, invincible, and completely untethered from the need for rest.
But they still need it.
Exactly. Their physical body, their heart, their kidneys, their muscles still require sleep to repair and function. If a manic patient goes 3 or 4 days without sleeping while maintaining relentless physical activity, they will enter a state of severe, dangerous physiological exhaustion. The heart can literally give out.
Which perfectly explains the logic behind the specific care planning intervention for a manic client. The guide says the nurse must offer high-calorie finger foods frequently throughout the day.
It is a brilliant, purely pragmatic intervention.
I think of it like a high-performance sports car whose accelerator pedal is jammed all the way to the floorboard. The engine is screaming, the wheels are spinning, and they are burning fuel at an astonishing rate.
Yeah.
But you cannot simply ask the car to stop and refuel.
You can't. If you sit an acutely manic patient down at a dining table with a plate of chicken, a fork, and a knife and tell them to eat a structured meal, they will physically not be able to tolerate sitting there. They will be up and pacing within 30 seconds.
They will just abandon the food.
Yes. And the rapid weight loss and nutritional collapse will accelerate the physical exhaustion. So, you hack the system. You hand them a high-calorie protein bar, a heavily peanut-buttered sandwich, or a piece of fruit that they can hold in one hand while they pace the hallway.
That's so smart.
You meet them in their motion. You provide fuel that doesn't require them to hit the brakes.
But what happens when that manic energy turns violent? The sports car crashes. A manic client suddenly strikes another client in the common area. What is the very first action the nurse must take? Do we immediately inject a fast-acting benzodiazepine? Do we run over and check the vitals of the client who just got hit?
The very first action, before any assessment or medication, is to call for a team of staff members to assist.
This is another one that fights human instinct. If I see someone get punched, my immediate instinct is to run to the victim and make sure they're okay.
And if you run to the victim, kneel down beside them, and turn your back on an acutely violent manic patient who is still standing right there, you are going to become the second victim.
The threat is still active.
Exactly. You cannot perform a medical assessment or administer an injection in an unsecured, violent environment. You must call for a team to establish physical dominance of the space, safety in numbers. Once the manic client is contained and the perimeter is secure, then you triage the victim. Order of operations is everything.
Let's look at a treatment for severe, treatment-resistant mood disorders that carries a heavy public stigma but is incredibly effective. Electroconvulsive therapy, or ECT.
A phenomenal tool, but one that requires meticulous physiological planning.
The scenario asks for the proper care planning for an ECT procedure. The correct action is that the nurse must monitor the client's cardiac rhythm via an ECG during the entire procedure.
Because the mechanism of ECT involves passing a controlled electrical current through the brain to intentionally induce a brief grand mal seizure.
Right.
That massive electrical discharge and the resulting muscle convulsions place immense acute stress on the cardiovascular system. You have to monitor the heart continuously for arrhythmias.
The interventions we don't do during ECT are fantastic lessons in understanding how the therapy actually works. One incorrect option suggests administering phenytoin 30 minutes prior to the procedure.
Which would be a disastrous clinical error.
Walk us through the pharmacology of that mistake.
Phenytoin is a powerful anticonvulsant. It's an anti-seizure medication used to stabilize the electrical activity in the brain. But the entire therapeutic benefit of ECT, the neural reset that lifts the depression, relies entirely on successfully inducing a seizure.
So giving phenytoin before ECT is like spraying a fire extinguisher all over a pile of wood right before you try to light a campfire.
Perfect analogy. You are chemically preventing the exact biological event you are trying to induce. The procedure would fail.
Another incorrect option is placing the client in 4-point mechanical restraints prior to the electrical current being applied, presumably to keep them still during the seizure.
Which is incredibly dangerous. During a grand mal seizure, the body's musculature contracts with violent, involuntary force.
Oh, I see where this is going.
If you tightly strap a patient's wrists and ankles to a rigid bed frame, the force of their own muscles contracting against those immovable restraints could easily snap their bones, tear ligaments, or dislocate joints. We use a short-acting paralytic and muscle relaxant, not leather straps, to manage the physical convulsions.
The nuance of these procedures is incredible. Let's move from mood disorders into the intricate web of complex personalities and anxiety. We're dealing with structures of the self that are fundamentally rigid or maladaptive. Let's start with borderline personality disorder, or BPD. The guide gives us a massive list of client behaviors and asks us to sift through and identify the manifestations of BPD.
BPD is notoriously complex because the pathology bleeds into every single aspect of a person's identity and relationships.
Here is the raw list of behaviors. Stealing money from family members, becoming highly anxious if left alone, exercising at the gym twice a week, holding the same administrative job for 12 years, hypersexualization with strangers, being married multiple times, incidences of self-injury, and physical altercations.
The challenge here is separating the healthy, routine human functioning from the diagnostic criteria.
Right, so exercising twice a week and holding the same job for a decade.
Those are distractors. They demonstrate long-term stability, routine, and a healthy continuity of identity.
But the remaining behaviors paint a textbook picture of DPD. Stealing money is an impulsive, boundary-violating behavior. Becoming highly anxious, if left alone, points to the profound, desperate fear of separation and abandonment that is the hallmark of the disorder.
Hypersexualization with strangers is an impulsive, potentially self-damaging behavior used to fill feelings of chronic emptiness. Being married multiple times reflects their pattern of unstable, intensely chaotic romantic relationships, the cycle of over-idealization and sudden devaluation.
And the tragic physical hallmarks? Self-injury, like cutting, which is often used to ground themselves during emotional numbness, and physical altercations, which stem from intense anger and poor impulse control.
The guide also points to the overarching feature driving all of this: emotional lability.
I can't imagine how exhausting it must be for the client.
It is a neurological roller coaster. Emotional ability is the rapid, almost instantaneous transition from one intense emotional state to another. They might be elated one moment and profoundly, aggressively despairing the next, reacting to environmental triggers with responses that are wildly disproportionate. It's like driving a car with a massive engine but absolutely no brakes.
How do we build brakes for them? The guide highlights two main therapies: dialectical behavior therapy, or DBT, and pharmacological support with fluoxetine.
DBT is arguably the gold standard psychotherapy for BPD. It doesn't just talk about feelings. It provides concrete, cognitive and behavioral techniques for clients, especially those struggling with suicidality, to tolerate severe distress without resorting to destructive behaviors. It teaches them how to ride the wave of the emotion until it crests.
And the fluoxetine, it's an SSRI and an antidepressant. Are we just treating underlying sadness?
We are treating the impulsivity. Fluoxetine is often prescribed in BPD specifically to help reduce the frequency of self-injurious and repetitive explosive behaviors by stabilizing the serotonin pathways that govern impulse control.
Let's compare BPD with two other personality disorders mentioned here, dependent and antisocial. For dependent personality disorder, the core feature is a desperate need for excessive external input from others to make everyday decisions.
They completely outsource their autonomy. They struggle to trust their own judgment on even the most mundane things, like what clothes to wear or what groceries to buy, fearing that making the wrong choice will lead to abandonment.
But antisocial personality disorder, this is a totally different threat matrix. This brings us back to the very first questions of unit management. These clients can present as charming, highly articulate, and totally in control. But underneath that veneer, they are deeply manipulative, impulsive, and lack fundamental empathy.
The charming exterior is just a tool for extraction.
The study guide asks for the best communication strategy for a client with antisocial PD. We know the right answer is setting firm, realistic limits on specific behaviors. But let's look at the instincts we have to fight here. Why shouldn't a nurse just try to behave in a friendly, warm manner to build rapport?
Because a client with antisocial personality disorder does not interpret warmth as kindness, they interpret it as a vulnerability to be exploited.
Oh, wow.
If you try to be their friend, they will weaponize that rapport to manipulate you into bending unit rules, giving them special privileges, or pitting you against other staff members.
What about acting as a role model for assertiveness, showing them how to communicate healthily?
That assumes the client wants to learn healthy, equitable communication. They do not. They want dominance. Assertiveness training is useless against a fundamental lack of empathy. You cannot role model a conscience. Concrete, unbreakable boundaries are the only language that effectively manages their behavior.
Let's transition into anxiety and the mechanics of panic. We have a scenario about a client with generalized anxiety disorder. The nurse needs to teach them a series of new relaxation techniques. The question is a matter of timing. Do you teach these techniques when the client is at the panic, severe, moderate, or mild level of anxiety?
This is a crucial lesson in how anxiety alters cognitive processing. The answer is mild.
Why only mild? Why not teach them how to deep breathe when they are actively hyperventilating in the severe stage?
Because of perceptual narrowing. As anxiety escalates from mild to moderate to severe, the brain's perceptual field, its ability to take in new information from the environment, shrinks dramatically.
Makes sense.
By the time a client reaches a state of panic, their cognitive processing is essentially locked down. They literally cannot hear, process, or retain a multi-step instruction on progressive muscle relaxation when their brain is convinced they are having a fatal heart attack. You must teach the tools when the anxiety is mild so the muscle memory is there before the crisis peaks.
That concept of the brain distorting reality perfectly explains this next scenario about defense mechanisms. This is one of the most fascinating psychological phenomena in the guide. A client has a favorite exercise instructor. They absolutely adore this person. They attend a class, but they return from the gym in a highly agitated state. Suddenly, the client is telling the nurse that the exercise instructor is pure evil, that they are a monster, and that their true dark nature is finally showing.
It sounds like the plot of a soap opera, but it is a textbook clinical presentation of a primitive defense mechanism.
The guide identifies this as splitting.
Splitting is incredibly disruptive to relationships and to the clinical unit.
Explain the internal mechanism of splitting to me. How does a beloved instructor become a monster over the course of a 45-minute spin class?
Splitting is the complete inability to hold cognitive dissonance. It is the failure to combine the positive and negative qualities of a single person into a unified, realistic whole. To a psyche utilizing splitting, people cannot be complex. They are either flawless, angelic saviors, or they are malicious, evil demons. There is no gray area.
So what triggered the flip?
Likely something incredibly minor. Maybe the instructor gently corrected the client's form, or ended the class 2 minutes early, or simply didn't smile at them.
That's all it takes.
Yeah, the client's fragile psyche cannot handle the nuance of, this is a good person who did a slightly annoying thing. The disappointment is too painful. So to protect themselves from the pain of a flawed reality, they flip the switch entirely. The idol is shattered, and the instructor is recategorized as purely evil.
It's a defense mechanism against disappointment. And this happens on the unit with the nurses, doesn't it?
Constantly. They will split the staff. They will decide nurse A is their perfect savior and nurse B is a sadistic tyrant. They will use this to pit staff members against each other, which is why absolute consistency and flawless communication between shifts is required to manage it.
All right, we are crossing over into the heavy pathology. We are entering the realm of psychosis, severe cognitive impairment, and the high-stakes pharmacology used to treat them.
Let's start with the profound fracturing of reality in schizophrenia.
A disease of profound complexity, categorized by how it alters the human output. The guide asks us to categorize a list of symptoms into positive and negative, and I think this medical terminology trips people up because in everyday language, positive means good and negative means bad.
Yes, we have to strip away the colloquial meaning. In psychiatric diagnostics, positive simply means the addition of an abnormal behavior, thought process, or sensory experience that should not be there. The disease has generated something extra. Negative means the absence or subtraction of a normal, healthy human function.
So let's run the list. Delusions of grandeur, catatonia,
Mm-hmm.
hallucinations, disorganized speech, and clang associations.
So those are all positive symptoms. The brain is producing extra distorted reality.
I want to focus on clang associations because it shows how deeply the processing is broken. It's when a patient speaks, but they choose words based on how they sound, usually rhyming, rather than what they mean, like the train in the rain feels the pain of the brain.
Exactly. The brain's linguistic center has misfired so severely that the phonetic rhythm of the words has completely overridden the semantic meaning. It is a positive symptom because it's an active generated distortion of speech.
And the negative symptoms. Alogia, which is a poverty of speech, they just stop talking.
Yeah.
Withdrawal from social activities.
And the guide specifically highlights a term, anhedonia.
Anhedonia is a devastating negative symptom. It is the absolute inability to experience pleasure from activities that were previously enjoyable.
That sounds awful.
It is the subtraction of joy. It happens because the dopaminergic pathways in the brain that process reward and satisfaction are fundamentally malfunctioning. The spark of life is just gone. When you have multiple schizophrenic or psychotic patients on a unit, evaluating immediate risk is paramount. We have a triage scenario. A nurse receives the morning shift report on 4 clients. Client 1 no longer recognizes familiar people. Client 2 cannot verbalize their basic needs. Client 3 is awake and wandering disoriented at night. And Client 4 is actively experiencing delusions of persecution. The question asks, who must the nurse assess first?
This is a classic test of identifying active versus passive threats.
The correct answer is the client with delusions of persecution.
Without question. Let's look at the others. The client with agnosia, not recognizing people. The client with aphasia, inability to speak, and the client wandering at night, they're all certainly at risk for passive harm. They might fall or suffer from neglect.
Right.
But the client with delusions of persecution believes with absolute, unshakable certainty that a person, organization, or force is actively conspiring to harm or kill them.
Which makes them an active threat.
Precisely. If your brain tells you that the person walking into your room is an assassin, your biological imperative is to fight for your life. That client poses the highest immediate risk for severe preemptive violence against the staff or other patients. You must assess them first to ensure they are contained and the environment is safe.
And how do we intervene when a patient is actively experiencing these positive symptoms? A client is sitting in a chair, visibly distressed by auditory hallucinations, hearing voices.
Right.
The correct, evidence-based intervention is to promote the use of music, giving them headphones to compete with the voices.
It is a brilliant, non-invasive sensory strategy.
But the distractor here is fascinating because it's exactly what a layperson would do. Inform the client firmly that the auditory hallucinations are not real. Why is that a terrible clinical move?
Because it is deeply invalidating. To the schizophrenic brain, those voices are not imagination. They're being processed by the auditory cortex as real external stimuli. They are as real to that patient as my voice is to you right now. If you tell them it's fake, you aren't curing the hallucination. You are just proving to the patient that you don't understand their reality, which destroys trust. Using music provides a competing auditory stimulus that can jam the signal, drowning out or distracting the brain from the internal loop without arguing about what is real.
Let's shift from psychosis to cognitive impairment. The vital distinction between delirium and dementia.
2 conditions that can look identical to a casual observer but require vastly different clinical pathways.
A client's family brings them in, reporting sudden, severe episodes of confusion. The nurse has to figure out if it's delirium or dementia based on assessment findings. Is the key finding a slow onset, aphasia, confabulation, which is making up stories to fill gaps in memory? Or is the client easily distracted?
Extreme distractibility is the hallmark, defining manifestation of delirium.
Walk us through the physiological difference. Why is distractibility the key?
Because delirium is an acute, sudden onset disruption of brain function, very often caused by a physiological insult, a severe urinary tract infection, a medication toxicity, or a massive metabolic imbalance.
That's temporary.
Exactly. The brain is thrust into chaos, losing its fundamental ability to focus, sustain, or shift attention. A slow onset, the loss of language, and the brain trying to neatly paper over memory holes with confabulation all point toward the chronic, slow, structural degeneration of dementia.
So how do we stabilize the chaos of delirium while we treat the underlying infection? The guide says a key intervention is to permit the client to perform their daily rituals.
Delirium causes massive internal anxiety because the world no longer makes sense. By allowing them to engage in familiar, deeply ingrained motor rituals like folding a blanket repeatedly or arranging their hairbrush on the table, you provide a small, tangible island of predictability. It gives their hands and mind an anchor, which significantly decreases agitation.
Now, what about general environmental interventions for clients with impaired cognition, whether it's delirium or dementia? The guide lists a series of actions, and we have to categorize them as either anticipated or contraindicated. Let's run through them. First, approach the client from the front.
Anticipated. A client with impaired cognition has degraded peripheral awareness and gets startled easily. Approaching from behind or the side can trigger an immediate, aggressive fight-or-flight response. You must stay in their visual field.
Give directions slowly and in a moderate tone of voice.
Anticipated. Their neural processing speed is slowed. You have to allow their brain time to catch up to your words. Furthermore, if you speak loudly, their damaged cognitive filter may interpret the volume as anger or aggression, even if you are just trying to be heard.
Decrease sensory stimulation and assign them a room near the nurse's station.
Both anticipated. Low stimulation reduces the cognitive load on a struggling brain, and proximity to the station allows for frequent passive observation to prevent wandering or falls without being intrusive.
Now let's look at the contraindicated actions. Use a vest restraint to keep the client secured in a medical recliner so they don't wander.
Highly contraindicated and frankly illegal. You cannot utilize mechanical restraints as a substitute for adequate staffing or simply to keep an elderly person from walking around. It is a profound violation of their rights.
Keep the client's bed at a comfortable working height for the nursing staff.
Contraindicated. The bed must be in the absolute lowest possible position, often with mats on the floor. If a confused client attempts to get out of bed in the dark, a bed left at waist height turns a simple slip into a devastating, life-altering hip fracture.
And finally, keeping the lights completely off at night in the bedroom and bathroom to promote deep sleep.
Contraindicated. Total darkness strips away all visual orientation cues. A confused brain waking up in pitch blackness will panic, exponentially increasing the risk of disorientation, wandering, and severe falls. A soft nightlight is essential medical equipment.
The guide also mentions two specific distinct therapies for dementia: a medication, Donepezil, and a communication strategy called validation therapy.
Donepezil is a cholinesterase inhibitor. It attempts to chemically slow the cognitive decline by preventing the breakdown of acetylcholine in the brain. Validation therapy is how we speak to them.
Give me an example of that.
If a 90-year-old dementia patient is agitated, pacing the halls, saying she needs to go pick up her young children from school, you do not use reality orientation. You do not say, your kids are 60 years old, go back to your room.
Because that forces them to relive the grief of aging and confusion all over again.
Exactly. You use validation therapy. You validate the underlying emotion behind the delusion. You say, you must really love your children. You are a good mother. Tell me about them. You meet them in their current reality to reduce their distress rather than dragging them painfully into yours.
Okay, we cannot avoid it any longer.
Right.
We have to talk about the heavy pharmacology.
The high-wire act of psychiatric nursing. These medications have incredibly narrow therapeutic windows.
These questions are truly life or death. Let's start with clozapine, an atypical antipsychotic used for severe treatment-resistant schizophrenia. The nurse is reviewing the client's morning lab results. What is the massive red flag that requires holding the dose? A white blood cell count of 2,500.
Because clozapine carries a severe black box warning for a condition called a granulocytosis.
What exactly is happening in the body during a granulocytosis?
The medication literally suppresses the bone marrow, causing a catastrophic drop in the production of white blood cells, specifically neutrophils. The body completely loses its immune system. It loses its ability to fight off any bacterial or viral invader.
Oh, what?
A normal WBC count is roughly 4,500 to 11,000. A count of 2,500 means their defenses are crumbling. If you administer that next dose of clozapine, the client could easily die from an overwhelming opportunistic infection. The guide also mentions monitoring for elevated temperature, myalgia muscle aches, and an increased heart rate, all clinical signs that a fatal infection might already be taking hold.
Next up, the precarious seesaw of lithium and sodium. Lithium is a foundational mood stabilizer for bipolar disorder. The scenario describes a nurse reviewing a lab report for a patient on lithium, and their sodium level is 128. That is hyponatremia, low sodium. Why is this low sodium level so incredibly dangerous for a patient taking lithium?
This is a beautiful, terrifying piece of human physiology. Lithium is a salt. On a molecular level, it looks very similar to sodium. The kidneys process lithium almost exactly how they process sodium.
I think of it like a bouncer at a nightclub who's told to keep out anyone wearing a red shirt, but the bouncer's colorblind. The kidneys can't really tell the difference between the two salts.
That is a perfect analogy. So if a patient's sodium levels drop too low, maybe from sweating, vomiting, or poor diet, the kidneys panic. They recognize a salt deficiency, and they attempt to hoard whatever salts they can find in the bloodstream to maintain homeostasis.
Right.
Because they are colorblind, instead of excreting the excess toxic lithium through the urine, the kidneys aggressively reabsorb it, mistaking it for sodium. This leads directly to a massive, rapid buildup of lithium in the bloodstream.
So a low sodium level directly causes severe lithium toxicity.
Yes, they are inversely related. You must maintain adequate, consistent dietary sodium to keep the lithium flowing out of the body.
Let's look at lamotrigine, another mood stabilizer often used for bipolar depression. The guide explicitly warns that a specific physical finding must be reported to the provider immediately.
A rash.
Which sounds so mild, just a rash.
It is never just a rash when a patient is taking lamotrigine. It is the potential precursor to Stevens-Johnson syndrome.
Explain the pathology of that.
Stevens-Johnson syndrome is a rare, severe, potentially fatal immune reaction to the medication. It begins as a rash or blisters, but it rapidly progresses to cell death, causing the epidermis, the top layer of your skin, to literally separate from the dermis and peel off the body.
Oh my gosh.
It is treated like a severe thermal burn. It is an absolute medical emergency, which is why any minor skin irritation on lamotrigine halts the treatment instantly.
Terrifying. Okay, let's talk about selegiline. This is an MAOI, a monoamine oxidase inhibitor, often delivered via a transdermal patch for depression. The question asks, what happens if a client on this medication eats aged cheese, smoked meats, or drinks certain red wines?
The infamous tyramine interaction.
Explain this, because to a patient, it just sounds like a weird food allergy, but the mechanism is far more explosive.
Monoamine oxidase is an enzyme in your body responsible for breaking down certain chemicals, including neurotransmitters like dopamine and serotonin. MAOI medications inhibit or block this enzyme to keep more of those feel-good transmitters in the brain. However, that same enzyme is also responsible for breaking down a naturally occurring amino acid called tyramine.
And tyramine is found in high concentrations in fermented, aged, or smoked foods.
Exactly. So if you eat a large piece of aged cheddar cheese while on selegiline, the tyramine floods into your bloodstream. But because the MAOI has blocked the enzyme, your body cannot break the tyramine down. It accumulates rapidly, acting as a massive systemic vasoconstrictor. It clamps down on your blood vessels.
Leading directly to a hypertensive crisis.
Yes. The blood pressure skyrockets. The patient experiences severe chest pain, a pounding headache, extreme tachycardia, and is at immediate risk for a hemorrhagic stroke.
Okay, let's look at a rapid-fire crisis scenario involving medications. A client with a severe personality disorder is rapidly escalating into violent, uncontrollable behavior. The guide gives us a list of potential physician prescriptions and asks us to categorize them as either anticipated or contraindicated. First, administering haloperidol 2 mg IM.
Anticipated. Haloperidol is a potent, fast-acting first-generation antipsychotic. It is used specifically in the acute setting to rapidly manage severe agitation, aggression, and psychotic behavior.
Holding their scheduled oral dose of buspirone.
Contraindicated. You should never hold it in this scenario. Buspirone is an anxiolytic and anti-anxiety medication. It has a slow onset for maintenance. If they are escalating, withholding the very medication designed to calm their baseline nervous system will only fuel the crisis.
Requesting a prescription for digoxin the Fusat.
Completely absurd and highly contraindicated. Digoxin is a cardiac glycoside used specifically for heart failure and certain arrhythmias. If the patient's heart rate is normal, administering digoxin would cause severe cardiac toxicity. It has absolutely no place in psychiatric de-escalation.
And finally, a little necessary nursing math to round out the pharmacology section. The nurse needs to administer diazepam 7.5 milligrams via an IV bolus for a patient in acute alcohol withdrawal. The vial from the pharmacy says it contains a concentration of 5 milligrams per ml.
It's the standard foundational formula, desired over have multiplied by the volume.
You desire 7.5 milligrams, you have 5 milligrams.
7.5 divided by 5 equals 1.5. You multiply by the volume, which is 1 ml. The answer is 1.5 milligram.
So you draw up 1.5 millimolars in the syringe. It's a simple calculation. But in the middle of a seizing patient, you cannot afford to get the decimal point wrong.
Never. A math error in an IV push is a critical incident.
Which brings us into the incredibly complex realms of substance use, trauma, eating disorders, and pediatric care. Let's start with alcohol. And the guide requires us to rigidly distinguish between alcohol toxicity and alcohol withdrawal because the clinical interventions are polar opposites.
Because the physiological states of the nervous system are exact opposites.
An unresponsive client is brought into the emergency department with severe alcohol toxicity. What is the absolutely correct? Prioritize action. Gather supplies for endotracheal intubation.
Because alcohol is a profound central nervous system depressant. In severe toxicity, the alcohol saturates the brainstem to the point where the brain literally forgets to send the signal to the lungs to breathe.
So they just stop breathing.
The expected clinical finding is profound, life-threatening respiratory depression. You prepare to secure their airway with a tube because they are on the verge of respiratory arrest.
But then look at the other side of the coin, withdrawal. A chronic alcoholic is admitted after a car crash with a staggering blood alcohol content of 325. 12 hours later, as the alcohol leaves their system, they start showing symptoms. What vital sign finding definitively indicates alcohol withdrawal? Somnolence, pinpoint pupils, or a blood pressure of 154 over 96.
It is the severe hypertension, the blood pressure of 154 over 96.
Explain the rebound effect happening in the brain here.
For a chronic, heavy alcohol user, their central nervous system is constantly bathed in a heavy depressant. The brain is fighting to stay awake. So, to keep the person functioning, the brain compensates by massively upregulating its excitatory neurotransmitters like glutamate. It pushes the gas pedal down as hard as it can just to counteract the heavy brakes of the alcohol.
But what happens when the alcohol is suddenly removed by admission to a hospital?
The brakes vanish entirely, but the brain is still flooring the gas pedal. The nervous system goes into massive, unregulated physical hyperactivity. That is why you see severe hypertension, extreme tachycardia, tremors, hallucinations, and potentially fatal seizures. The distractors in this question, somnolence, which is sleepiness, and pinpoint pupils are classic signs of an opioid overdose, completely unrelated to the hyperactive storm of alcohol withdrawal.
And for the long-term recovery of substance use. The guide explicitly states that a client participating in a 12-step program must be taught to obtain a sponsor before discharge.
Because the clinical evidence is overwhelming, peer support dramatically increases the chances of continued program attendance and long-term sobriety. You do not send a fragile, newly sober nervous system out into the world alone. You link them to someone who has survived the exact same neurological storm.
Let's shift the focus to trauma and grief. For adult clients experiencing PTSD in group therapy, the guide recommends a specific intervention to reduce anxiety, using guided imagery.
It's a powerful tool. The nurse assists the client in closing their eyes and vividly imagining a restful, completely safe place. It intentionally activates the parasympathetic nervous system, lowering heart rate and bringing them out of the trauma response.
But the distractor here is horrifying. Aversion therapy.
It is practically barbaric in this context. Aversion therapy involves pairing a negative, painful stimulus with a behavior you want to stop, like snapping a rubber band on your wrist when you crave a cigarette.
Oh, wow.
Applying a punitive, painful stimulus to a trauma survivor experiencing anxiety would cause massive re-traumatization. The guide also notes that we must educate the families of PTSD clients to expect the client to experience profound feelings of isolation and detachment from others. It's a primary protective manifestation of the disorder, not a personal insult to the family.
And how does PTSD present differently in pediatrics? A school-age child lost a parent in a traumatic event 8 months ago. What specific behavior indicates the development of PTSD? Is it clinging behaviors? Sleeping more than usual? The correct answer is a lack of interest in an upcoming holiday.
Children process and manifest trauma very differently than adults. Clinging to a surviving parent or alterations in sleep are normal components of acute grief. But a total, pervasive loss of participation in significant, normally joyous activities like completely ignoring Halloween or their own birthday 8 months later is a key marker that the trauma has fundamentally altered their neuroemotional landscape. The capacity for joy has been blunted.
Speaking of the timeline of grief, when does normal bereavement cross the line into clinical pathology? A partner died 4 months ago. The nurse is assessing the surviving spouse. Which statement is the clinical red flag for complicated grief?
The guide zeroes in on this specific phrasing. I feel so empty. It's hard to get up every morning.
Why is that complicated grief versus just the normal, heavy sadness of losing a spouse?
It comes down to the disruption of basic daily functioning. Wishing you had been nicer to them or thinking about them constantly throughout the day is normal bereavement. But when the profound, heavy emptiness actively prevents the client from physically getting out of bed, caring for themselves, and carrying on normal activities a third of a year later, it marks the transition from a normal grieving process into complicated clinical depression that requires intervention.
And what is the nurse's role in supporting grieving parents who have lost a child?
Suggest forming or joining a weekly support group. Just like with substance recovery, shared lived experience is a profoundly powerful tool. Validating the unimaginable pain with peers reduces isolation.
Let's dive deeper into pediatric mental health and the specific medications involved. Autism spectrum disorder. A hallmark manifestation that nurses must teach parents to look out for during early development is language delay.
Early identification of communication and social deficits leads to early, vital interventions that can dramatically improve long-term functional outcomes.
Now, we have two ADHD medications with entirely different risk profiles. Let's look at atomoxetine first. A Guardian reports that the child taking this medication has a reduced appetite, fatigue, sweating, and dark urine. The expert nursing priority.
Sound the absolute alarm on the dark urine.
Why?
Because atomoxetine carries a severe, rare risk of hepatotoxicity liver damage. Dark, tea-colored urine accompanied by fatigue and sweating is a classic late-stage sign that the liver is failing to process bilirubin. It can progress rapidly to acute liver failure and death. The medication must be stopped immediately.
And the second ADHD medication, methylphenidate. What is the primary adverse effect the nurse must monitor for?
Tachycardia. Methylphenidate is a powerful central nervous system stimulant. While it paradoxically improves focus in ADHD, it acts systemically as a stimulant. You must watch the child's resting heart rate and blood pressure closely to prevent cardiovascular strain.
Moving into the incredibly complex pathology of eating disorders, let's focus on anorexia nervosa. A client is admitted to the medical unit at 60% of their ideal body weight.
That is a profoundly fragile, life-threatening physical state. The heart muscle has literally atrophied.
The correct nursing intervention during this critical phase is to encourage drinking 125 milliliters of fluid each hour while the client is awake.
Hydration is critical. Dehydration in a severely malnourished body leads to rapid kidney failure, electrolyte imbalances, and ultimately fatal cardiac arrhythmias. But it must be a steady, heavily monitored rehydration.
But the distractor here is incredibly tricky because it appeals to our desire for patient comfort. Allow the client to eat their meals independently in their room. It sounds like we're respecting their autonomy, right?
It's a terrible, dangerous idea. The core pathology of anorexia involves intense, desperate deception regarding food intake and weight. If you allow a severely anorexic patient to eat alone in the privacy of their room, there is a massive, almost guaranteed risk that they will hide the food in napkins, throw it out the window, stuff it in their pockets, or immediately engage in purging behaviors. Meals must be strictly observed by staff to ensure the nutrition actually enters and stays in the body.
Let's wrap up our clinical exploration with community and outpatient care. How do we keep these patients safe once they leave the hospital walls? A client has severe schizoaffective disorder, experiencing both psychosis and severe mood swings. To keep them safe at home and prevent readmission, the nurse recommends ACT assertive community treatment.
It is the platinum standard for comprehensive psychiatric care.
What makes an ACT team different from just seeing a therapist?
ACT teams literally bring the hospital to the community. It is a mobile, interdisciplinary team of nurses, psychiatrists, and social workers that provides 247 crisis intervention, direct medication delivery to the home, and life skills advocacy. They don't wait for the patient to show up to an appointment. They go to the patient, preventing the tragic revolving door of continuous inpatient hospitalization.
And in the realm of public health, how do we address intimate partner violence? The guide asks how a nurse implements secondary prevention in the community.
We have to define the 3 levels of public health prevention first. Primary prevention is stopping the violence before it ever happens, like teaching healthy coping and relationship skills in middle schools. Tertiary prevention is treating the profound damage after it happens, like physical rehab, trauma therapy, or legal advocacy.
So what is secondary prevention?
Secondary prevention is all about early detection and rapid intervention. So the correct answer is establishing widespread screening programs in clinics to identify at-risk clients. You are trying to find the hidden cases in the early stages before they escalate to tragedy.
Our final clinical scenario deals with the subtle, insidious nature of family dynamics. A nurse is observing a family counseling session. One of the children looks directly at a parent and says, "If you do my homework for me, I won't bother you for the rest of the day." The study guide highlights this specific interaction as a classic example of what?
Manipulative behavior.
To a layperson, that just sounds like a sassy kid negotiating. Why is it clinically significant enough to be highlighted in a psychiatric text?
Because it reveals the diseased underlying communication structure of the entire family system. The child is not communicating directly. They are not saying, "I am overwhelmed and I need help with my math." Instead, they are utilizing their own behavior or the threat of intentionally annoying, disruptive behavior as currency to extort a desired outcome from the parent.
They're holding the parent's peace and quiet hostage.
Exactly. And if this manipulative pattern isn't identified and dismantled by the therapist, it breeds deep resentment and establishes a blueprint for highly dysfunctional, coercive relationships long into the child's adulthood. They learn that extortion, not vulnerability, gets their needs met.
Wow. Okay, let's pull all the threads together and synthesize this massive undertaking. We have covered an incredible breadth of material today. We didn't just rattle off the correct answers from a flashcard. We mapped the entire psychological and physiological logic of psychiatric nursing.
We traced the precarious tightrope walk of lithium toxicity in the kidneys. We debated the profound, unyielding ethical duties of non-maleficence and justice. We broke down the strict, life-saving rules of mechanical restraints, and we decoded the subtle, hidden linguistic cues of trauma, grief, and suicidal ideation.
And throughout this entire exhaustive deep dive, a singular, powerful theme kept emerging. The distractor answers on that study guide the wrong choices. They aren't just random, silly guesses generated by a computer. They represent our deepest, most natural human instincts.
Yes. The deeply ingrained social instinct to comfort a crying person with false platitudes about how it gets better. The instinct to take a lonely, fearful person and introduce them to a crowded room of friends. The instinct to just give an exhausted, hyperactive person a sleeping pill to solve a noise issue. Or the instinct to step close to an angry person and ask, "Why are you so upset?"
But clinical mental health care demands that we override those everyday instincts. It requires us to lean entirely into structured, evidence-based, and frequently counterintuitive interventions.
Because the ultimate goal of a psychiatric nurse isn't just to be polite or to make a social interaction smooth. The goal is to fundamentally heal the mind and to keep people physically alive during the most volatile, vulnerable moments of their entire lives.
Which leaves us with a final, provocative thought. As you step away from this study guide and look at the real world, and you see how often the common sense approach is actually the most dangerous option on a locked psychiatric unit, it makes you reflect on your own life. When might your own natural instinct, the instinct to avoid a conflict, to offer false hope to a struggling friend, or to project your own feelings onto a messy situation, actually be the absolute wrong approach to helping someone who is in a genuine crisis? Sometimes, the absolute kindest, most loving thing you can do for someone is to set a firm, unbreakable limit.
A profound and challenging thought to carry forward into your practice in your life.
Thank you so much for joining us on this deep dive into the source material. We will see you next time.